I know the guy.
They've sort of done that before, but it's never quite figured out that action. It's hard.
Come on in and have a seat. There's nothing but to get started tonight. And I wanted to give an overview. We have more training manuals up here, so you left yours at home tonight. We have pens if you want to take notes, and later I'm going to have you fill out some paperwork in case you, after the training, you decide you want to get involved. Up here, and I'm going to leave them on the table, I have some resources that you might find interesting. This one is various books having to do with pastoral care and caregiving. This one's called God, Medicine, and Suffering. It's quite interesting. Douglas John Hall, God and Human Suffering. Families at the Crossroad. Family Ministry. The Suffering of God, which is an Old Testament perspective about suffering. And this is a book that could help you if you know somebody with a substance abuse problem, understanding and counseling persons with alcohol, drug, and behavioral addiction. So there's just a few resources. You are welcome to borrow them. Just return them. And don't be like me because I borrow things and could be better about returning them. But I know who they belong to and where they belong.
Oliver Chill.
Yeah. I want to give you a little overview of the training sessions last week. You're all the same people here, so you know what we did. All that is available on video. So, for example, John Peterson, if you want to take a video home, you can get last week's session.
Okay.
You're welcome to do that. And then we have a bunch of videos, so they can be check out at a church office along with the training manual. People can complete the work at home. Tonight we have a special treat. We have Bill and Darcy Morris coming, and Darcy is going to give us the practical side of things, which I think is good. Right now, up till now, we've been talking about the theoretical, about the theological overview, the biblical view, the kind of the high level stuff, and maybe the fundamentals in terms of getting your head on for it. But Darcy Morris is going to talk about what it looks like to go visit somebody in their home, what you can do.
You mean, so if that wasn't scary enough, now we're going to...
Yeah, right. Yeah. Yeah. If it wasn't scary enough. And then it's going to get scarier because her husband, Bill Morris, who works in a hospice setting and works with end-of-life situations medically. Oh, yeah. Do you need to close the door?
Yeah, I think so.
There's an ammonia smell in here that I was trying to air out. It should be done.
Well, you'd rather faint or die.
Choice. Yeah, look at that. That's fine.
I'm going to take asphyxiation.
All right. Bill works in end-of-life situations, so he's actually going to come. He's a medical doctor. He's going to come and talk about what happens at the end-of-life stage. And you may be called, if you so indicate on your form that we'll fill out at the end, you may be called to minister to somebody in the congregation who's in that stage, and this will help you know what to expect, and what that looks like, and how you can prepare for them. So, if you'll all turn to page 11 of our training manual. Does anyone need a manual? There's a stack up here. And we talked about this a little bit last week, but I think we can talk about it a little bit more, although in fast forward. Welcome. At the beginning of a biblical overview of pain and suffering. And the thing that we need to emphasize about this problem of pain and suffering in the world is that God is aware of it and that God cares about it. And so we don't believe in an absent God. We don't believe in a God who sort of created the universe and let it go off and do its own thing. He's very much involved. He cares. He doesn't intervene when we want him to all the time, and for that we have no answer, honestly. But we do know that he cares. And we know that he entered human suffering in the incarnation and on the cross. And so there's that sense that identifies with it. But God, I want to give us just a quick overview of the word cry in the Old Testament. Now, this is not cry with tears. This is to cry out. This is the cry of anguish. It's the same word that the earth is spoken of the earth when it cries out for vengeance because of Abel's blood that Cain spilled. So it's that same word. It's this crying out for relief. And so you'll see that men without food cry in the Old Testament, and God hears it. People expecting to die because the Egyptians were advancing on them. The Israelites cried out to the Lord. In Judges 4:3, the Israelites cried out to the Lord for help. And some of the Deuteronomic laws talk about what happens when what kind of punishments are meted out when certain things happen. And a woman being raped will cry out. And if she's in the countryside and nobody's to hear her, she's not to blame. Victims of injustice, they cry out. The widow and the orphan. The Lord says, if you abuse them when they cry out to me, I will surely hear their cry. If you take your neighbor's possessions, if your neighbor cries out to me, I will listen, for I am compassionate. And God also has an expectation about what He wants. Talking about the vineyard in Isaiah 5:7. And He expects justice, but He sees bloodshed. He expects righteousness, but He hears a cry. So God hears this sense of crying. And in that sense of God listening to our suffering and being involved in it, it's also appropriate to have something called a lament. And this is a type of literature in the Bible, and there's quite a bit of it. The lament, which basically says, this is terrible. I feel terrible. This is no good. We talked last week a little bit about it being okay to be angry with God. Well, it's also okay to be disappointed with God. It's okay to cry out in your anguish. This one's a good one to read out loud, just for the edification of the group. Could somebody read the first 11 verses for starters? Oh, yeah, go ahead.
Hear my prayer, O Lord. Let my cry come to you. Do not hide your face from me in the day of my distress. Incline your ear to me. Answer me speedily in the day when I call. For my days pass away like smoke, and my bones burn like a furnace. My heart is stricken and withered like grass. I am too wasted to eat my bread. Because of my loud groaning, and my bones cling to my skin. I am like an owl of the wilderness, like a little owl of the waste places. I lie awake, I am like a lonely bird on the housetop. All day long my enemies taunt me. Those who deride me use my name for a curse. For I eat ashes like bread and mingle tears with my drink. Because of your indignation and anger, for you have lifted me up and thrown me aside. My days are like an evening shadow. I wither away like grass.
Notice this is very different from a lot of the other songs that you'll find in the Psalter. What was it in there that stood out to you? Anybody?
God threw him aside.
Mm-hmm. Yeah. He's lodging a complaint against God. You have lifted me up and thrown me aside. Can you say that to God? Yeah, absolutely. The psalmist does. Yeah. Anyone else? The imagery in here is pretty powerful. A lot of organic imagery, a lot of household imagery.
Every phrase or every verse virtually has a negative, in the sense that first verse, let me cry out, is a negative, isn't it? Mm-hmm. Do not hide your face from me. Third one, my bones burn like a furnace. Fourth, I am wasted to eat my bread, and so forth. Mm-hmm. Things are really tough.
Yeah.
Big time.
I thought it was kind of interesting, in verses 1 and 2, he starts out appealing to God.
Mm-hmm. Right.
And here in verse 11, he ends, or verse 10, he's I don't know if he's blaming God, but he's acknowledging that, basically it's God who has afflicted him.
Mm-hmm.
Yeah, the indignation and anger in verse 10. I mean, that's he's blaming God.
Mm-hmm. And it doesn't say why God is angry, or even if God is angry. It's just maybe he senses or he feels like he must be on God's bad side right at this moment, and that's what he's expressing.
Yeah, so it kind of leaves it open. We don't know at this point.
Mm-hmm.
Maybe if we read the rest, we might know a little more. But
Yeah.
we don't know if is it because of his own guilt where he feels that God has thrown him aside, or just that he knows that God is a sovereign Lord, and therefore any affliction,
Mm-hmm.
it comes from God ultimately.
Mm-hmm.
We don't know if what his views on this are,
Right.
where he's coming from.
Comes from or is permitted by maybe God. Yeah. But and that's a great point. If God is all powerful, to a person suffering, him making it happen and him allowing it to happen make no difference to them semantically whatsoever. It's happening to them, right? They don't care about that difference.
Yeah, and God knows it.
Yeah. God knows it. That's true. Yeah. And so we're left with, all we have is the permission to express this agony, this lament. And I think it's amazing that our scriptures allow this kind of language, or even lift it up. That speaks to how the scriptures are for the whole range of our experience on life. And of course Jesus quotes the Psalms a lot. My God, why have you forsaken me? There's some lament. Even on the cross, there's a lament. Yeah, you were going to say something like that.
I was going to say how common it is for people when they're in distress, and especially if it's been building up or for a length of time, to be really angry with God and think that he's turned his back.
Mm-hmm.
To be angry, really angry. And it's really common to hear that from people.
Yeah.
It reminds me a little bit of the relationship between kids and parents.
Uh-huh. Yeah.
Because kids will say just what they're thinking, but it's okay. Within limits.
Right.
The parent understands.
Yes. Yeah. That's a good point. Yeah.
I guess the other question I have on those 11 verses is, maybe this guy deserved everything that was happening to him.
Mm-hmm.
And he wasn't saying that.
He's not saying that he deserved it.
That's right.
So maybe he did. And he's confused as to why this is happening.
That's right.
Yeah. That's a good question.
Or he may be totally aware of everything that he's done, and now he's trying to return to God, say, how afflicted he is because he knows of his guilt, right? Now he's trying to come back to God.
Mm-hmm.
I don't like that association with guilt and this. That seems really wrong-headed to me.
In my work with people who are dying, I just saw a lady the other day who said, "What have I done that God is punishing me so?" And she asked me, and I have to chop in to get with that one.
Does this sound like, since you mentioned, this sounds like somebody who's near death in some ways. I'm too wasted to eat my bread. My bones cling to my skin. I would say it the other way around. My skin clings to my bone, but this is what it says. I lie awake, thinking of not being able to sleep, not being able to eat, being very skinny. Does it sound like a person who?
Yeah.
Yeah, we don't know.
Well, it says answer me speedily, so there's some confusion or something he's not aware of.
Mm-hmm. Well, the lament is maybe what he wants the answer to. It's a list of complaints. Why is my situation like this? Let's somebody else read 12 through 17. Because it does change the tenor, yeah.
But you, O Lord, are enthroned forever. Your name endures to all generations. You will rise up and have compassion on Zion, for it is time to favor it. The appointed time has come for your servants to hold its stones dear and have pity on its dust. The nations will fear the name of the Lord, and all the kings of the earth your glory. For the Lord will build up Zion. He will appear in his glory. He will regard the prayers of the destitute and will not despise their prayer.
What happened here? There was a bit of a change of course.
Completely changed.
Yeah. I was just wondering the same thing. What happened between 11 and 12? Maybe a good night's sleep or...
Right.
Or just start off with jest.
Okay.
Sometimes just putting
There's
it
something
out
about
there.
that. Absolutely.
Okay, I said it, and
Now that I've got that, yeah. Or I have all these questions about why this is happening to me, but yet I trust in the Lord. You know, there's this beautiful ending to Habakkuk. You know,
though everything falls apart.
Yeah, there's no fruit on the vine, and the fold is empty, and the field yields no harvest. You know this, but there's this yet I will trust in the Lord. Who's my hope? You know, and that's common in this kind of poetry. It ends with faith. It starts with lament, but it ends with faith. And this is all future stuff. It's very interesting that the hope is that God will do something in the future. You're going to raise up Zion. You're going to... I love that it says your servants will hold its stones dear and have pity on its dust. That even the tiny dust specks are going to get some attention. So there's this sense that he's appealing to a God who's really concerned about the smallest things.
And in verse 13, he trusts in God for the appointed time.
Mm-hmm.
So
Yeah.
trust is there.
Yeah. I didn't want to spend too much time. Last week I think we ran over on the scripture stuff. You can't do enough scripture stuff. If you look at page 14, what I was talking about is the incarnation, the sense that Christ became human flesh and had every pain, every sorrow, every feeling, every temptation that humans face, but yet was without sin. But also entered into human suffering so completely that he went to the cross and died. And that suffering was really actually a deeper suffering than we probably know, because he really was alienated from God on the cross as well. And so that lament was something that actually became true. It wasn't just a lament for him. It wasn't just saying, this is how I feel. This was a description of what was happening with Christ on the cross. And so, again, when you're dealing with somebody who's suffering, they may not care about this. But this is our DNA. This is our what we're made up of as Christians, that we understand that we proclaim hope out of the story of a person who experienced the ultimate suffering on our behalf and then was raised again for our new life. And so that has a lot to say about how we view our own suffering and how we minister to other people. I wish I had more time to talk about that, but I want to give enough time to Darcy and Bill, and I think we'll start with Darcy, if that's all right. And if you just, yeah, great, you've got a handout. Tell us about yourself. Try to stand right about here. I'll zoom back a little bit. We are taking this for video. Sure.
My assistant.
Just one?
Yeah, there's just one. My name is Darcy Morris, and I come to the caregiving background. First, I came as a volunteer. I worked for the Center for Living with Dying in San Jose as a volunteer. And so I know what it's like to volunteer and go in and visit people, and the fears and the insecurities of what that's like. And then I had a job for the Council on Aging in San Jose, where I was the head of the caregiver program, which basically sent volunteers into nursing homes to visit people. And then I worked a little bit for the Caregiver Alliance, doing workshops to churches on how to visit homebound people. So I'm going to be talking a little bit not just about caring for a chronically ill, but basically anybody that's homebound, about visiting people in nursing homes, in hospitals, because as lay people, that's what we'll be doing. And I'm going to kind of focus on some practical do's and don'ts, as well as really what we're called to do. And so I apologize for the small font. It came out smaller than I expected. So I wanted to start out with a visitor's prayer. Lord, let me visit with joy and with compassion. Let me bring your light to those who may be experiencing darkness and despair today. Help me to be fully present to each person I visit, listening with care and concern and offering openness and humor when appropriate. Let me speak words of comfort and encouragement, and may my actions be thoughtful and loving. May my hands, my feet, my heart, my lips be used in total service to those I visit, and may I bring to them the same care and concern that I would want if I were in their place. Thank you for allowing me to serve you and bring you praise through these visits. So this is kind of the framework of how we enter into a visiting relationships. And I would say it's really one of humility, because we all suffer as people. And to be allowed into someone's home, to walk alongside them in that suffering, it's really a privilege and an honor. And that's the first thing I would tell volunteers is a lot of volunteers would approach caregiving in this rescuing mentality of I want to go in and many of them had agendas that were religious agendas. I want to save people. I want to counsel people. I want to make suffering better. And the first thing I would say is when we walk into a caregiving situation is to understand that we don't cure people's suffering as volunteers. It's kind of like we walk with them for a short part of their journey, and we offer comfort, encouragement, humor, whatever it is that we can kind of move them a little bit through the journey. And our part is really brief, but it can be really powerful. So you never want to underestimate what you're doing by being present, but you want to go in and really kind of a spirit of reverence. So that's what I put here is our purpose is really to come alongside a person for a small portion of their journey with love and compassion, to offer support, compassion, and understanding. And I really want to clarify that we're not offering counseling. We're not there to be therapists. We're not there to offer advice. My background is social work. We're not there to offer social work and to connect people with resources. And that's where I've seen a lot of volunteers stray. And that's where I see a lot of volunteers get overwhelmed and burned out, because that's not what we are. We're not social workers or physicians or, therapists.
We talked a bit about boundaries last week, and, this is exactly what you said was, you're not their doctor, you're not their counselor, you don't get involved in their family disputes, you're there for them, and you do for them what you can do.
Yeah. And that's in some ways the good news, because it really frees us up to be completely present for people. And the power of our presence is amazing. I mean, if you think about exchanges that you've had where you've had a bad day and someone sends you the note at the right time saying, I'm thinking about you, or you're discouraged and you get that email, that comes on your phone that's just enough to kind of encourage you. Brief moments that we're with people are really powerful and can really change people. I think about that when I was watching a friend in a triathlon, and it was really interesting. It was the one in Santa Cruz. It was interesting to see how families would line up at one spot. Someone would come by, and they'd go, 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 throw water on them. We love you, and then they're gone. And then they'd sort of travel, and the family would get in the car, catch them at another point. Go, 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 we love you, you can do it. And then we move on to the next spot. And I kind of see us as caregivers as that. So we come along for part of the journey, and we try to read what the person's needs are. Do they need encouragement? Do they need a pep talk? Do they need someone to hold their hand? And we're with them to get them along a little bit further in their journey, and then we catch up with them at a different point. So in caring for people, I think it's really important, and I think in a lot of trainings we underestimate, we don't talk enough about preparing to visit people. And I have some practical things here about calling to ask if it's okay if you visit. I think whenever we're working with people, we want to give them as much control over their situation as we can, because people are feeling powerless and they're feeling like they're losing control over their situation. So little things like calling and saying, is it okay if I visit, as opposed to calling and saying, I'm from church and I will be there to visit. When do you want me to come? We want it, things, the way we phrase things really can help to make people feel like they still have a little bit of control, and whatever little bit they have is really important to them as they're losing more and more of that. If you're bringing food items, you want to make sure, these are just sort of practical things. The one that I really wanted to focus on was to take a few minutes to prepare yourself emotionally for the visit. Often what I would see in teaching people was they can't find a house, they're stressed, they're squeezing it in between taking kids to work, they pull up in the driveway, jump out of the car, and I used to accompany people, so I was actually with them the first few times that they would go into a nursing home. And then they rush in, and they're, I'm so sorry I'm late, I have to get the kids, and you're bringing that energy, in with you to the person. But also, we need to be kind to ourselves. And some of us are visiting, if we're visiting cancer patients, we might have experienced a family member who went through the same thing. If we're visiting someone who's elderly, maybe we've lost someone close to us who's elderly. And visiting can often bring up a lot of our own emotions and hurts. And so I really encourage people, when you're in the car, to just take a moment. I used to often pray for the person I was visiting, but I would also picture myself taking all my stuff, putting it in a suitcase and closing it, and saying, these are my issues. Take a deep breath, take a few minutes to just sit outside the house and prepare yourself for that reverence, and that respect of entering the house, being fully present for them. And they can really feel the difference. Again, we want to bring the goodness of the outside world, not the chaos and the hecticness of the outside world into the house. And I'm going to talk a lot about pulling the outside world in. And the other thing is to treat a hospital nursing home room with the same respect that you would a house. Often people think because we're in a hospital or a nursing home that we can open doors, people are walking in and out. There's a lot of disrespect. There's a lot of violation of boundaries in those situations. So if you're in those situations, it's really good to treat it like you would a home, to knock on the door. Is it okay if I come in? Because again, it's just really reinforcing respect for that person. If we're in a house or a nursing home or a hospital, whenever you move something, make sure that you move it back. Just to basically treat the environment with respect.
One of the things, Darcy, that I find that I have tried to remember to do, it's hard to remember, is, the only thing really you have in a nursing home room or a hospital is your bed. And so to ask for permission to sit on the bed, because that's sort of their space. And I, all the time, I have to remind myself to do that, because you just assume, I'm just going to sit down. But, it is a good, and usually people are, of course, they never say no. But to ask, I think, is really a good thing.
So for visiting tips, the first thing people always used to ask me, and the biggest source of anxiety was, I don't know what to talk about. What do I say? The first thing is it's okay not to say anything, especially if people are very ill. It's okay to be present. But I know that, especially if we're not comfortable with a person, that's not good enough. We all want to say something. And so what I encourage people to do is to walk into a situation really trying to learn, and almost with an inquisitive mind about, I'm going to try to see what I can learn about you. And again, that empowers the person, that somebody's interested in them. And we all like to tell our story. We all have stories to tell and things that are important to us. And some people just need a little more coaxing. And there's always clues, even in the most stark nursing homes. There's usually clues of something that you can find to be a conversation starter. So, like what I have here is take hints from the room. to ask people about themselves. There might be a picture next to the bed, and you can just say, oh, that's a lovely picture. Is that your granddaughter? And that can sometimes elicit things. I remember one guy I visited in a nursing home had piled all these John Wayne movies, and he was just a big John Wayne fan, and that was the only thing I could find in the room. There weren't any pictures. And I said, do you like John Wayne? My brother loves John Wayne. And that just took him off, a road of remembrance of John Wayne and his favorite movies and, the old movie theaters. And there he was. And at that point, all I had to do was listen, and enjoy the story, because again, everybody has such great stories to tell. And if you can put aside your nervousness and just say, this is a fascinating person, I really want to learn as much as I can about this person's story, they can pick up on that, and they'll start talking. I remember being in a nursing home and a woman had an Afghan, at the foot of the bed, and I asked her about that. There's pictures, even what they're, a glass of juice or something. There's always little clues around the room that you can kind of just ask inquisitively without being nosy, but most people really love to tell their stories. The next step is listen. Every person has something they want to say. Listen to them. Refrain from offering advice or getting involved with family gossip, like what you were saying. I find that, I've worked with a lot of different ages, and I have a lot of kids, and, it just seems that our universal need as people is to really be understood, no matter what stage of life we're in, or how successful or how much we're suffering. It just seems that we all really want people to understand. And when we walk into a room, I've noticed that people seem to have something they really want you to understand. And if given the opportunity, they will, no matter what, a John Wayne movie, if someone wants you to understand that his family isn't treating him fairly, he'll use the John Wayne movie to go around, and say, I used to watch John Wayne movies with my son. By the way, my son won't listen to me, and my son never visits. That's why you use clues as a room, just as a way to get you rolling. People will get to the issue they want to get to, is my experience. There's always something they feel that they want to be understood, and it's our goal to find out what it is, and then to be a caring, supportive presence, and to listen to it. And we want to do that without judgment, without getting involved, without saying, oh yes, you're right, I know your mother, and she's not very supportive, is she? That's what we want to refrain. But just to nod and let them talk. It has a very, healing effect on people to feel that whatever's bothering them, somebody is there and somebody is trying their hardest to really understand. Not just to listen, but to really understand what's being said. Share when appropriate. And again, we have to be really careful, because every now and then I'd get a volunteer that it was almost like their therapy session. So they would come in with pictures of their kids and stories and talk, and then the poor person is more exhausted than before the visitor even came in. And then they'd say, would you like me to visit again? No, I'm fine. Really. But the part of sharing that I like is that we sometimes underestimate how truly isolated people are. When you're in a dark room, sitting on your couch for days on end, or a nursing home for days on end, you really are shut out from what's going on in the world. And we take for granted how much little things mean to people. Sharing, what our job is to really pull in part of the world with us. Like the prayer says, we're to be lights. And so we want to bring a little bit of that sunshine from the outside into the nursing home, into the dark bedroom. And that can be something as simple as a pumpkin from your garden, or a tomato from your garden, because someone in a nursing home probably hasn't seen a tomato from a vegetable garden in a really long time. Someone may not have seen a flower that you just picked from your front yard, to bring in. This really struck me because when I had the job as nursing home trainer for the caregiving program, I was pregnant. And it was amazing to me how many people wanted to just come up and touch my stomach and just it was like I was a celebrity. And I mean, no one else treated me like that, but it really dawned on me that these people have not seen a pregnant woman probably in a really long time. And then when Allie was born and I brought her in, it was really touching to actually let people hold her. And people actually cried because they were just so moved at having the chance to hold a baby again. And that's kind of a bigger thing, but even little things that we can bring in. A recording from a concert at church that we heard, or a program from church, it helps people feel connected to what's going on in the outside world. And when you're shut in and you're lonely, that's really, really important, and it's really special. And it's a real gift that we can bring them. Touch is very powerful. To hold someone's hand, to look them in the eye. But I really do encourage people to ask, and I know that can be uncomfortable. But some people don't like people to hold their hands. And it's us humbling ourselves to have the courage to ask and to say, would you like me to hold your hand? And I was amazed at how many people would say yes to that. Humor is wonderful. Don't be afraid of it, but don't overdo it. Sometimes we're afraid to laugh. Like I was talking about this spirit of reverence. We walk in and it's like, oh, how are you? In the hushed tones. It's okay to laugh. It's okay, to take the lead of the person. There are often people make fun of their own situations. We don't want to exploit people or overdo it or bring in jokes of the day. But I think to smile and to see humor in life, and again to bring a little bit of that from the outside world, is really a special thing when people are feeling really isolated. And the last one is to really think about people's dignity. Again, people really have lost a lot of control. Sometimes it's physical control. Sometimes it's just that they've lost a role. Maybe they were a mother and they don't feel that they can be a mother anymore. Maybe they were a spouse and they lost their husband and now they don't feel like a wife anymore. There's so many levels of loss that people feel when they're ill or they're homebound, that whatever we can do to make them, again, feel control of their lives is really important. So it comes in little things like again, asking, not telling. I give some examples of, would you like me to come again, rather than, well, I'll be coming again next week. That can make people really feel pressured, or would you like me to bring something? Would you like me to bring pictures? Would you like me to bring a sermon tape? What can I do for you? I think to really treat people with respect and to honor the fact that they still have decisions and control over their life is a great thing. And then ending the visit, besides just thanking the person, because again, we have to remember that we're kind of walking into someone's sacred space. To be with somebody when they're suffering, again, it's really an honor and a privilege. When Bill's sister was dying, I really felt that. I really had this sense towards the end of her life when she was really suffering that I felt so privileged and honored that she would let us into that space, because I knew how hard that was for her to be out of control, to be fragile and vulnerable, and to be one of those people that's allowed in. It's an incredible honor. So I think to really mean that when we leave and to thank people is really important. And to ask them if they'd like you to pray with them. People tend to really like that. And to also take care of yourself after the visit. Because again, the temptation to visit, to be present, to run back in the car, run to the grocery store, and it's gone. But we need to really care for ourselves too, because when we're caring for other people who are suffering, it brings up a lot of our own suffering. It brings up a lot of our own pain that we've experienced. And I think it's really important to take time to pray about that and to just take a moment of quiet, to take some deep breaths. If it's too much, to go for a walk, but to really pad that time with some time for yourself, because a lot of visiting can be very triggering of our own lives and our own things. And sometimes we can learn a lot from other people about ourselves. That's the magic of grace, is that the more we minister to other people, the more we learn about our own life situations. So God uses us, and then He uses the people that we care for in our own lives. It's kind of a circular thing. So I just wanted to close by a quote by Dorothy Day, who, I don't know a lot about her, but my friend gave me her book. She was like the head of the Catholic worker movement or something. The word comfort means to be strong together, to have fortitude together. There is the reminder of community. Once when I suffered and sat in church in misery while waves and billows passed over me, I suddenly thought with exaltation, I'm sharing suffering, and it was immediately lightened. And again, I think that that's really our goal, is not to fix, but to come alongside someone and to just really share in their suffering and to listen and to try to really understand. So that's all I really got. Thanks.
Would you take some questions?
Yeah.
Ms. Harrison?
Sorry.
I don't have a question, but a comment. I like that the one thing you mentioned about not asking, what can I do for you, but giving some suggestions. Can I bring you a tape? I'm in the hospital.
Yeah.
And I know that when the ministers come and, can I do something, my first impulse is to say no because I don't want to put anybody out or, and you kind of hit a blank. But I like that idea, of putting some suggestions, even if it's magazine or call, something. I like that.
And I think what you do is, again, if you're visiting someone over time, you use the first visit to sort of, like I said, to take stock of the room and to really try to get people's story. And then from that, you can get clues of how to follow up. So if you learn somebody really loves to garden, then you can say, I have this wonderful book on gardening, would you like me to bring it? And then you have developed a connection. Or, whatever it may be. I have this great John Wayne movie at home. Would you mind if I brought it so you could watch it? So you can really use the first visit, again, to kind of investigate and say, what can I learn about this person's story? And then that'll give you ideas on what to suggest. Anybody else?
One of the things you talked about was bringing the outside world in. However, isn't it true that in cases where people are shut in or suffering or ill, the outside world may be very scary and intimidating. They may not necessarily like. How do you make the difference between bringing in the outside world that's non-threatening between the outside world that could be very threatening?
Well, I think that when in doubt, you start small. So in other words, I wouldn't bring in my baby to somebody that could scare, But I might, if I knew that they were connected to the congregation, I might bring a picture, of a church gathering. Or if I knew that the person was into quilting, maybe I could bring a cutout in a newspaper of a quilting show and just thought you might be interested, something like that. Because I think people really do want to feel connected to what's going on. I think that's a really good point. You don't want to just overwhelm the person and start parading all these things into their room, but I think that in small little ways, as you get comfortable with someone, again, you start small. So if you know that they're gardeners, like I said, you could bring a tomato in or a pack of seeds. I thought this picture was really pretty or something like that. I think it also reinforces to people that you really are hearing what they're saying and that you really have understood their lives. It kind of reinforces that I've been listening and I hear who you are. And I think if it's done in that spirit, people really will honor it. And then I think as you get to know people, you get a feel for a little bit more and more. And again, you can also ask. and just say, would you like it if I brought a book in, or something like that. So.
You mentioned inadvertently bringing the chaos of the outside world in by not preparing yourself ahead of time, and that might be the thing that somebody would react to the most too, is getting the vibe from you of all the busyness and craziness of life that they.
And people
just
do that.
Be without, yeah.
Visitors really do. They would. I could see that, just the stress, and often visitors that I would train had a lot of anxiety going into the room, and so. I remember the first time taking somebody in, and actually, interestingly, she later became the director of the program when I left. But her first visit, she came in and she was so nervous, she hit the cup of water, and the water fell over on the bed, and then she picked up the thing, and she was like, I'm so sorry. And she was just a nervous wreck, because she was so, nervous. So, again, she developed a wonderful relationship with that person, and I think that sincerity can cover a million errors that we make, when people know that we're sincere and that we're really trying, because we're just human, But you don't want, I remember I did have one visitor that would come in and talk about her kids and talk about, and I really had to work with her about, just come in quietly and just sit, ask how they are, and really try to keep the stress of your kids and your carpool out of that room, because that's, like I said, that's a little too much of the outside world. So.
Did you role play ever with these to help people break into?
Yeah, we did. We had volunteers go through a pretty in-depth training. That was pretty much a whole day, and they had to actually go through an interview process too, much like a job. Because sometimes we felt like people maybe had some issues that maybe they needed to wait a little bit, like if someone close to them had died, a month before, maybe taking care of cancer patients was too soon. Sure. And often people feel that way. They feel grief, and they want to put their grief into something rather than processing it. So we did role play, and I would always go with people, definitely the first time, usually 2 or 3 times, and just kind of help them negotiate it, because nursing homes are particularly scary, even scarier than houses, because of the other people that are around and working with the staff, and so. Anybody else? All right, well, thanks.
Thank you, Darcy. Great. What we'll do now is I want to treat everybody to some great snacks here. We've got all sorts of goodies here, and there's some drinks over there in the corner that have been cooling all evening. So let's take 5 minutes and refresh ourselves, and then we'll come back at it.
In fact, that's the subtitle of the movie, the whole series.
Welcome back. I really want to thank Darcy for that very practical presentation. That was excellent. It's what we needed. And good practical advice. The next step was going to be a biblical overview of death and dying and our hope and resurrection. That's for you to do on your own, because we don't have time for tonight. Okay. I want to give all the time that we have left to Bill.
I thought maybe it would be like a rock concert. You have to bring them up and then bring them down. Yeah. No. Sort of finish it up.
Well, yeah, we're going to end. If you leave 5 minutes at the end, so if you can go to 25
and then
minutes.
you can sort of tie up.
Well, tie it up, and then we have some paperwork. We have some paperwork to do, and I want to try to honor the departure time, because last week we got out about 10 minutes, maybe more. And
But we all got home.
Was that?
But we all got home.
Y'all got home, and most of you came back. So yeah, come on up, Bill.
All right. So I'm going to talk a little bit about what I do. Is I do a lot of different things with end of life, and as a physician, sort of people who are suffering a lot. I do So to give you a background, I'm the medical director at Driftwood Convalescent Home, a local nursing home. So I know sort of the nursing home side of things. And then in the hospital at Dominican, I'm part of one of the physicians that does the palliative care consult service. So we're called in mostly, we've done it now for 4 or 5 years, and we're called in mostly. And then number one reason we're asked to see patients is because of doctors and families, they call it goals clarification, sort of what we talk about. It's just sort of helping people sort out what they are going to do. So that's a lot of what we do. And then we also manage symptoms and stuff. But we thought when we were starting the program, we'd be called to manage things like pain and nausea, vomiting, and all that. But that's really sort of a minor, although we address it. The bigger challenge is to sort of help people sort out what they can do and what's available and talk about options. So I thought we'd talk a little bit about sort of the system of care that's in the community, so you have a sense of where you all and as part of Barnabas team would fit in. And then I also I'm part of Hospice Santa Cruz County as one of the physicians, so I see that aspect of care too. People enter into hospice, and we can talk and you can have some discussion about when that happens in a certain spectrum of things. But as people either age and get ill, or they are sick because of illnesses at a younger age. We have, unfortunately we have, somewhat of a system to care for them, but there are a lot of barriers and a lot of frustrations that family members have, and a lot of it comes around our sort of disjointed healthcare system and who cares for what and where and how do you pay for whatever. And in the old days, people would I think, if you would ask someone 200 years ago, how would you want the end of your life to go? What would you want to die suddenly, or would you want to die gradually? Everyone actually said they'd rather die gradually. That's 200 years ago, that's what people wanted. And why was that? Well, people wanted to have warning. They wanted to donate some money to the church so that things would be taken care of when they get to heaven. Amen. They want to, and now we gradually spend all our money so the church doesn't get it. But they would, and there really wasn't a lot of warning often for death. You would basically be working in the field, you could cut yourself and you get blood poison and you die, or you get in an accident and you die, or you rupture your appendix and you die, and you get cancer and we didn't have chemotherapy or surgery or radiation, so you die. So. It wasn't felt to be a good death when you didn't have warning. And most people died suddenly. Now, it's always what you don't, what you can't have is what you want. Now, we tend to peter away slowly and gradually. And people keep going, even though they don't necessarily want to. We're struggling with a patient over at the hospital now who has advanced colon cancer, and she... the nurses are frustrated because they feel that she said to them multiple times, I don't want to go through all this radiation and this treatment. And yet she won't tell her doctor, her oncologist that. And so we have to sort of mediate and we have to talk with her. And when she's feeling better because we manage her symptoms, she wants more treatment, even though it's not curative, but just to maybe try to give her some more time. Now, she would have probably not be alive now if it wasn't for modern medicine. We're not going to cure her, but we're going to give her a lot more time. Now, the quality of that time may not be what she necessarily wants. And so it's hard, and the nurses see that, and the patients sometimes will express it and other times won't. So it's very hard. It makes our goals clarification tough. But we have the hospital, which, if you're really sick, you get to go into it to be cared for. But, in the old days, you could get into the hospital easier and stay there longer. And nowadays, you're in and you're out pretty quick. As soon as you no longer meet what they call interqual criteria, these guidelines. And they're sort of silly. They're sort of cut off. If your sodium level is 121, you don't meet criteria, but if it's 120, you do. But now we can override those. But there's sort of these guidelines that get set up that you have to be in the hospital when you no longer are sick enough or requiring enough care, we call it intensity of service, then people have to leave. And often they're not ready to go home. And so where do they go? Well, their choices are they can go to a skilled nursing facility, and you can go there for, as long as you have the money to pay privately. If you've been in the hospital for 3 days, we call that a qualifying stay. Then patients get to go to a nursing home, and if they're over 65 and have Medicare will pay for some rehabilitation time, but only up to about 100 days. And as you go further through those days, the amount that Medicare pays the nursing home to get you stronger drops. At the end of 100 days, doesn't matter if you still need a lot of, you're still getting stronger and getting better, you have to start paying privately. And it's very expensive to be in a nursing home. Maybe $400, well, let's say $5,000 a month. It's pretty expensive. So it adds up pretty quickly. So it's hard. Now what happens, and unfortunately, is people end up, if they can't go home, they end up spending to a point down where they spend all their money and then they go on Medicare, or Medi-Cal, Medicaid. And then Medi-Cal, Medicaid will take over the bill. So the government eventually pays. Or all of us do, through taxes. So it's sort of too bad, because then you're spending all your money. And no one, maybe you earned up a lot of money, you want to pass it on to your kids. You don't get to, because you got to spend down. So that's if you're really sick and you need that sort of care. So sometimes people say, I don't want to go to a nursing home if I have to start paying privately. Now, more and more people have long-term care insurance, so that often will kick in for, I know my mom has long-term care insurance, and she'll get coverage in a nursing home for 3 years. But then if she lives in more than 3 years, you got to start paying down. So it's a very crazy thing. So if you want to go home, you can go home with sometimes home health, which will provide some care to help, maybe, let's say, give you medicines to check on you, give you some physical therapy and help. But that doesn't go on forever. And that is often, and it's also not 24 hours a day. It's a nurse coming in, or maybe home health aide, physical. And there's different caregivers in the community that you can hire to do that. Help by Angels and different groups that that you can hire someone, and they're pretty expensive to get. Certainly to get 24-hour care, as expensive as a nursing home is, it's probably less expensive to be in a nursing home than it is to hire 24-hour care, unless you sort of do it. I know over the hill when my sister was sick, we hired these big Samoan. There's a network of the Samoan families that take care of people because they're good caregivers. And Darcy said to me, she said, I would never hire a Caucasian American to care for anyone.
I didn't actually say that. No, but I worked with a woman who ran a board and care houses in San Jose. She had 5 board and care houses, which are basically just homes that people convert and have people live in. She was the one that said
she would never hire.
That she would never.
She said, because we just don't respect
because
her.
Our culture doesn't teach people how to care for other people, and
especially elders.
Yeah, especially older people.
Older folks. And we go to there's in between home and the nursing home, there's this care service called assisted living. Oak Tree Villa. There are different levels. Some are small houses, and some are big. Oak Tree Villa, Dominican Oaks, Paradise Villa. There are different ones in the community that you can go to, and they're usually staffed by people who aren't Caucasian Americans, but they really have a respect for the elders, and they care for them very well. I mean, they do a great job, but they're not cheap. The smaller ones maybe are a little less expensive than the Oak Tree Villas and what's the other one? Scotts Valley. That's the Oak Tree, right? Oak Tree Villas in Scotts Valley. And those are fancy and nice places, and you can get different levels of care depending on how much support you need. But when you're there, you tend to need a little more support than you would at home to be independent. So those are the sort of the different sort of settings that we all might be seeing people in. Often, a question that comes up is as someone tries to set their goals, as what we're going to do. I think that it's helpful to sort of know what I call disease trajectories. To sort of get the sense of where people are, because it helps sort of put us in the context of what our caregiving is going to be and what the future holds. People with, and people who do a lot of end-of-life care sort of have 3 or 4 different categories. The first one that's easiest, I think, is, in some ways, is people with cancer. People with cancer tend to actually do pretty well, pretty functional, be able to take care of themselves, manage their what we call activities of daily living for quite some time. But as death nears, they get weaker and weaker. And I think it's helpful to think about it, and I often explain this to families when we're talking about it, it's as if this edge is sort of going off, is dying. So people with cancer tend to be approaching the edge from a distance, okay? And as they get closer to the edge, you get weaker and less able to care for yourself. And you need more and more help from others. You need more and more assistance in bathing, and at some point you get to the point where you can't get out of bed. But that's usually pretty close with cancer. Okay, so the edge, the closer you are to the edge, the more help you need. And with cancer, you're coming from a distance. And we, although we're not always the best predictors, if you really look at and you speak honestly with an oncologist or physician, we have a pretty good idea how long someone will live. But the studies, interestingly, that have done at prognostication in medicine teach us that doctors are not very good at telling someone how long they have to live. If it's in a relationship that you have a long-term relationship with the patient, doctors tend to, anyone tend to be optimistic. They want to hope for the best, and so they tend to overestimate how much time someone has to live by a factor of 8. So some people have proposed, doctor says you have a month, 8 months to live, you probably have a month. That's in the study. This is just sort of scientific studies. Now, people who don't have much contact, ER physicians, intensive care unit physicians, maybe hospitalists now that, we're all taken care of by these hospital doctors in the hospital that don't know you, don't have a long-term relationship, don't know how you've done before. Those doctors tend to be pessimistic. And if anything, maybe a little more accurate than the doctors that have a long-term relationship and really don't want to see this relationship end. So they tend to be more optimistic. So that is cancer. Now the other, a lot of people, if they don't have cancer and nearing the end of their life, what are they going to die? Well, people tend to have either chronic debility, of an accumulation of a lot of different illnesses. A little bit of arthritis, a little bit of maybe a few strokes, a few, their kidneys aren't working well, maybe have a little heart failure, maybe a little bit of emphysema from smoking, or they may have bad cases of heart failure or emphysema. Or, unfortunately, as you get older and older, you get more and more likely to get dementia. Whether it's Alzheimer's dementia or whether it's from multiple strokes or other sort of subtypes, less common types of dementia. The reality is that it gets pretty common as you get above 80, 90. I mean, a good percent of people will develop dementia. And in the old days, we never saw it because what? People died of, the appendectomy or the blood poisoning. We didn't see it. People died when they were 40 or 50. And at 60, in those ages, our life expectancy is extended. We start to see more and more dementia. And the problem with dementia or any of these disabling conditions is that instead of walking from a distance to the edge, you're walking along the edge. So, and I explain that to people because it really helps them to say, when am I going to die? Well, you might walk along that edge for a long time. You might walk along that edge and you might get a little closer to the edge. And remember, the closer you get to the edge, the sicker you are, the more weak you are, the more assistance you need. So you get a little weaker, and then what happens? Go to the hospital. And maybe you get tuned up a little bit, your medicines are adjusted, you might treat an infection that got you to the edge, and then you pull away from the edge for a while. And then you go along for a little longer, and then you come back to the edge if something else happens. But because you're so close to the edge, sometimes it's not that hard to knock someone over the edge and they die. But one of the big challenges that I see that we try to talk to people about at the hospital, when they come onto hospice, this issue's sort of been resolved, but before they come onto hospice, one of the big issues is this walking along the edge? Is this for you living, or is this for you a dying? And if it's a dying, if it's an existence that people don't feel like is something that really to them is living, then sometimes we have conversations around, okay, maybe this is now, maybe it is dying. And next time you get really close to the edge, we don't have to treat you. We don't have to treat the pneumonia. And I'll say to people, the old pneumonia we used to call the old person's best friend. Because when people got sick and weak and got close to the edge, before we had antibiotics, the pneumonia would take them before they had to live an extended period, maybe in a skilled nursing facility, or with caregivers, or with, but on the other hand, some people say that this is certainly living. This is good. I don't mind being along the edge. Caregiving, I have good caregivers. I still enjoy the interactions I have with my friends and my family. And for those people, we should make efforts to keep them going along the edge. But really, it almost comes down to, at some point, a real choice about which path they're going to take. Are they living or dying? So that's a very, in the old days, we didn't have to make that choice. We didn't have to talk about it because it was made for them by their illness. But we can keep people going a long time in the nursing home, unfortunately. If we treat every infection, we send them to the hospital for adjustment of their dosing, to maybe, have this surgery or that. We can keep people going a long time. And we always have to ask the question, is this what you want? Is this what, just because we can do it doesn't mean we should. So it's a struggle. I mean, it is a hard thing to do. And sometimes, I have to say, in my palliative care consultations at the hospital, I always remember an elderly woman who was independent and functional, which, by the way, is a good predictor of how you're going to do. If you're independent and functional, you get sick, even if you're in your 90s, you have a pretty good chance of bouncing back if we aggressively treat you for, let's say, a pneumonia or a kidney infection. Even if you're really weak and disabled and disoriented during that treatment, it's going to take a while to get you back. And you're going to have a long rehab to get your strength back. But it's not impossible to do. And we, sometimes I think we have to resist in the hospital the temptation to say, oh, I wouldn't want to live like that. So therefore we should let you go. And sometimes the palliative care team is called in and we sit down with the family and the patient and we say, what do you want? Do you want to try to get back to how you were before? Are you willing to put the work in to get back to how you were before? We think maybe you can get back there, but it's going to take a couple months. Was it a life that you enjoyed and that it was living rather than a slow dying? And if patients answer yes, then sometimes the palliative care team will say to the doctors, we should treat her infection or put in the pacemaker or do those things to get people back. And the doctors sometimes get bugged at us because what they want us to do is sometimes we're called in to sort of pull the sheet over their head, and say, we don't want you to get more, we want to make you no code and do all these things. So it is a challenging, area to talk about with these patients. And how do you all fit in? Well, I think it's very important, Darcy said, patients need to feel that they certainly have value. That someone cares enough to go out and see them, that they are listened to, that their opinions are heard. I think that's very important. And I think I worry that maybe one of the reasons why some people say that my life isn't worth living is because they don't have the sense that anyone listens, or that there's nothing to go back to because their life's pretty bad. So the more we can make, someone's life that of value and give it worth, the more I think people will have clarity in their decisions. People tend to, I think, be pretty know what they want to do. Sometimes it just takes one person to visit or one person to be present to sort of help sort that out. That's it. Anything else? Was that my time?
No, you got 5 more minutes.
Okay.
If you want, I was thinking about
maybe a little bit about hospice.
Well, if somebody were to walk into a room, what would they see? What would their senses
on hospice
encounter in hospice or in an end-of-life situation, so that it can prepare them maybe mentally before they walk into that room?
So when patients are nearing the end of their life, it sort of it surprises me, and to some extent, that people tend to die in a very similar way, despite maybe having many different reasons, different causes. So a patient with cancer might die in a similar way to someone with lung disease, or with heart failure, or with dementia. And by that I mean that, there's not a lot of variations in sort of the physiologic patterns of your body shutting down. So people tend to get more and more sleepy, spend more and more time in bed. They have less and less interaction with other people.
their appetite goes away. So people will, and sometimes they will say things like, I want, In-N-Out burger. And so the family will go out and get an In-N-Out burger and they'll take a bite. And then that's all they want. They just sort of more wanted the taste than really a hunger to eat something. And so appetite goes away, and actually thirst might go away as well. And all people really need is something to moisten their lips or to get a little sip or ice chips. They don't really need to drink a lot. Sometimes, we've taught, that food is love and food is support. So we want people to eat. We want to cook for them and then eat. And we're offended if they don't. But I think as people are dying, we often have to give them permission not to eat. And that's okay. And it's okay not to drink because you're preparing for the end as the body starts to shut down. People might not wake up at all. They might not have energy to talk. But we think, I don't know how we know this, but we say this is sort of folklore, that people still hear. And that things can be said still, and people will understand what is said. So that both means you can still talk to patients, even though they may not respond, and also you need to be careful what you say about your patients, because they can hear what you're saying. So speak respectfully and directly and say the things, and I always encourage people to say what they want to say, even though the person can't respond back. And sometimes they can respond just enough with maybe a squeezing of the hand or something to notify that they heard what was said. We like to have, obviously, people die like in Hollywood movies where they're very comfortable and peaceful, and they just sort of, they're awake until the very end, and then they say their goodbyes and pass away. But it doesn't happen that very, very often, unfortunately. And sometimes people can be, look like they're uncomfortable with fast breathing. And what I tell people, oftentimes, is you need to look at someone's face to see if they're really in distress. Because if someone is comfortable, usually their face looks pretty peaceful. They might be breathing fast, and they may have a gurgling sound in there as the secretions from the mouth start to collect on top of the vocal cords. But if someone is not reaching out in panic and their face is relaxed, we think they're comfortable. We don't think they're short of breath. And it may be that fast breathing is part of what happens as the body shuts down. Now, if you are agitated, reaching out, your face looks uncomfortable, you're moaning, that patient needs to probably be given medicine. And hopefully, hospice would be involved to help titrate that medicine and make sure the person stays comfortable. What else goes on at the end? People might develop, not to scare you, but people might develop bed sores that are smelly, or people might be not able to control their bowels or their bladder. And so that might happen as well if you're visiting someone near the end. People often will get mottling of the skin, so their hands will turn purple. And that's just the blood shunting to the central part of the body. There's an interesting phenomenon that sometimes will occur, and it hasn't really clearly been understood, but people might be not responsive for days. And then, for whatever reason, they wake up for a short period. Sometimes it's a few minutes, sometimes it's hours, sometimes it's a whole day. And they can talk and visit, and family members sometimes will call hospice and say, it's been a miracle, this person's been healed. But invariably, they slip back into how they were before, and they die. And it may be, if you want to think of a scientific reason, it may be just that sort of the different adrenaline and catecholamine substances being sort of a gush of those from the adrenal gland. It just sort of like giving someone a shot of adrenaline, and they wake up. And they're with us for a while. We don't understand why. Other things that can happen at the end is that people can see visions. And sometimes you'll be talking with someone and they'll be looking off in the corner up on the wall. And I would encourage you to say, do you see something? Because often they'll say, oh yes, I see Aunt Betty, or I see my wife, or I see Uncle Joe, or I see my husband. And interestingly, invariably, they tend to have already died, people that have already died. And they tend not to be a scary thing to the patient at all, even though it's sort of eerie to necessarily have someone say, yeah, there's someone sitting up there on the edge of the bed. And sometimes they describe little cherubs or angels that are sitting there. And they say, what does it look like? Well, it's a little baby, and they're smiling. Or they might say things like, my husband wants me to, come, I'm ready to go dancing. They're ready, they sort of, often there'll be an analogy Or like people will start to do things like pack their bags, or say I'm ready to go, and they're saying it's okay to go now. So you'll hear this, and it sort of sends a shiver down your spine when you're there when that conversation happens. But it happens, and I would encourage you not to be scared or freaked out by it, but just to know that it's not uncommon that people will have visions. And I call them visions rather than hallucinations, because hallucinations implies that they're crazy, and they're not crazy, because these are often a reassuring vision that they have. Sometimes people can have scary hallucinations, and those may need to be given medicine through hospice if the person is on hospice. But we don't need to give medicine to treat these visions that are reassuring and peaceful. So my experience is that patients often don't tell you about them unless you ask. And so I've had consults at the hospital where a family's not ready for to sort of let their loved one go, and I will say, well, we talk about things that might happen at the end as we're preparing the family, and then we go into the patient's room and we ask her. I asked this one lady, "Have you seen visions?" And she said, "Oh yes, for days now. I've been seeing my husband who died 5 years earlier, and he says that I've fought this cancer hard enough, and it's time to go." And so that helped the family, sort of let go. And they said, okay, yeah, because Dr. Morris said it, and now it's going to, so I almost sort of took on a priestly role of sort of being able to say this is something, and it wasn't any, it was just from experience, that I'd gotten that. I'd gone through this enough that I was able to anticipate what might happen. And it helps family, and it is reassuring to family members that someone is, waiting or preparing or, encouraging them that now's the time. What else that happens at the end? I think those are the main things that I like to sort of talk to families about.
I think what you said about them still hearing is very important.
Yes.
And to, you can come and talk or read a book, but you don't spend a whole lot of time there, but just to, and those reassuring words is okay to go. It's okay
right. It's okay to let go.
It's okay to let go is fine to say that sort of thing. Unless the family isn't doing that.
Right.
Then
That's
you
a good point.
need to keep your ears open.
I tend to think of that in terms of the family giving permission.
Yeah.
The other thing that's interesting, people will have these sort of, they'll talk about things like, oh, it's time to go now, I'm going to go dance, or they'll come up with this sort of story that they may be talking to you about if they're still awake and talking. And I'll often encourage family members to engage in that conversation, whatever sort of vision they have. And sometimes, as I've done this, it sort of becomes clear what they're talking about. Like this person is, they're meeting their wife who's died, going dancing, and they're ready to go. And they're ready to go now. And it's sort of almost a preparation, sort of a verbalization. They can't say I'm dying, but they say this is what's happening. I'm ready to go. And it can give you an insight. And sometimes it can be, as long as it's not upsetting to the person, it can be helpful in helping them process. Instead of saying, oh no, you're not going dancing. Sometimes families will do that. You can't go dancing, dear. You've been in bed for a week. What do you mean going dancing? And that's sort of the conversation that, and then they shut down and they don't talk about that anymore. Mm-hmm. But if you can just listen, oh, you're going dancing? Where are you going? And then that sort of brings out a conversation. It becomes clear that what they're really talking about is they're passing on. They're getting ready. But it's fascinating. I don't know if anyone's been around someone who's died, but there really is a sense that once they've died, the body's different. I mean, I think that more than anything else, it convinces me of the spirit because, in one moment, you have the body and the spirit, and the next, you don't. It's fascinating. And my father died, my sister died, both I was there, and it just really clearly shows me that it's like Darcy said, it's a real privilege to be present with that, and it's not an easy thing to do. And I think that if you go out and visit, the chances are at some point you may, be with someone at the end. Hopefully they'll be on hospice, and if you are there, I would encourage the family to just have the family call hospice, and they'll take care of everything. Sometimes families get sort of paralyzed by it. They call hospice, and they'll come in, and they should send someone out, take care of arrangements, and to do what they need to do.
Yeah. Refer. refer.
Yeah.
Yeah, you're not responsible for that.
You're not.
Just to in that case, to put them in touch with the resource, which is important. Yeah. Excellent.
Okay. Any questions?
This isn't a question, it's just a comment. My husband and I have had, I think it's 3 or 4 experiences with some of our family members, and they were eventually went to hospice as they aged, and they were getting worse. And I just can't thank hospice enough. The first time it happened, it was my mother that was dying, and we had small children at that time. And the hospice nurse said, "Bring your children in to the meeting." And they got those little girls prepared for where Grandma was going to go and that sort of thing. And all kinds of other very tender, very helpful things happened in all 4 situations. And I think it helped us so much because we were always the ones that were the engineers of all this. We took care of a lot of the family members as they began to pass away, and so that seemed to always fall on our laps, and it was a good experience in the long run. It really was.
It is. It doesn't seem like it at the time. But
once a decision is made, it sort of takes the burden off. You know what I'm saying?
And somebody else is helping you,
right.
Or holding your hand.
That's right.
And they're experiencing knowing what to do and what to anticipate.
Right.
What happens if, and I know we can, you say refer hospice to them. What if the family is just, they don't want hospice?
Yeah.
I mean, I know we would not push it, but it really makes the end more difficult if.
Well, I think within our congregation, and if you see a real need for hospice or anticipate, always you can call me. Hans-Erik can get a hold of me. I can talk with them about, this is not. I mean, I think there is still some bias against hospice that it kills you. And actually, my mother-in-law, your dad's wife, said, hospice, he goes to this church somewhere, I don't know where, Holy Roller Church, but thinks that hospice is evil.
Yeah.
And there is that attitude among some people that, it kills you, and life is sacred, and we should never participate in anything. And hospice, we have to reassure people sometimes, is not encouraging death, it's not speeding up death, it's just focusing on the quality of life that we have left. More and more, I think hospice is becoming what we call more open access, meaning that things that used to be hospice really was, giving some morphine and hand-holding, not that is not much, because it's tons, But we've gotten more, we sort of evolved with palliative care now, thinking that sometimes we'll admit people to the hospital that are on hospice because symptoms aren't controlled. Or we'll give some radiation if it's to improve someone's symptoms. We'll give IV medicines or IV hydration. We'll start to do, in some ways it's sort of, the old hospice nurses are very sad about that because it's sort of like medicalizing dying. When dying is sort of like birth, and the whole natural childbirth movement was sort of a response to making it so medical. It's a disease to have children. Or it's a disease to die. No, it's part of, life. And so hospice sort of rose out of that. And now we're sort of almost in some ways coming back to making it more medical. So we have to resist that. But it reassures sometimes the people that really want aggressive things done, that we can still do things, and it's become medical more and more. It used to be a doctor wouldn't see patients on hospice. It would be the nurse. And now more and more doctors are like, I go out and visit a lot of patients on hospice if issues come up. Other doctors who work with me on hospice will go out to see patients and do a full sort of formal assessment. So we'll encourage people in that way. But I can talk with them about hospice. The other thing I would say is Hospice of Santa Cruz. There's Heartland and then there's Hospice of Santa Cruz. Hospice of Santa Cruz has this program called Transitions that they're committed to keep going. And what it is people that aren't ready for hospice, often, that's often who we refer, that should go on to hospice but can't accept hospice. And transitions, it's not a lot of support, but it's a connection, and they sort of learn not to be too scared of hospice, because it's a social worker that goes out and visits and connects and makes appropriate referrals, and then also can sort of just gently guide them so that when they're really ready, hospice can come in quickly. So Transitions is the program. You can call Hospice of Santa Cruz and say, I have someone that I think might be appropriate for transitions. And we'll look at it and maybe bring them on. It's a free program. I think it may have a sliding scale for people out of London, but it's a good program in that sense. So that sometimes is a nice transition to get people onto hospice.
That's Heartland?
Heartland is the other hospice in town, and Heartland doesn't have a transitions program, or we call it sort of a hospice transition program. But they're the other, and they're a good hospice too in town. And Heartland is based in Monterey. Hospice of Santa Cruz County is just in Scottsdale. So the two hospices, I think, we really are fortunate in Santa Cruz. We have a very good network of hospice and palliative care, and knowledge and comfort with these issues in our local community. And I'd be glad to talk to anyone.
Thank you so much, Bill. Welcome. This was excellent. And I want to do just a little bit of paperwork, and it was occurring to me that two things occurred to me. One was we probably scared you completely away from this. So, no, that's not true. Could you pass these around? This is your chance, and take these home, unless you want to sign the dotted line tonight. This is your way of letting us know that, yes, I want to be involved, and these are the things I'm comfortable providing right now. And so it says when you can start working, that you agree with our confidentiality policy and what you're willing to do and how we can get a hold of you to give you an assignment. And it occurred to me, as Darcy was speaking, that if you would like to do some of these home visits or hospital visits, but you would like me to go along with you for the first 2 or 3 or 1, 2 or 3 times, absolutely I will do that. And if that will help you to get introduced to how we do that, that's a great thing to do. It also occurred to me that 3 hours of training is pretty slim, but it's a start, so it's a way to start. And what I envision for the Barnabas team ongoing is if you're in a care relationship, we need accountability. We need to see how you're doing, and you need to grow. So if you're in a care relationship, there's basically a mandatory monthly meeting that you need to come to, where you check in and say, this is what's in confidentiality, this is what's happening in my care relationship, and then we'll have more of these kinds of sessions, more sort of tune-ups, and it'll keep going. So it's not to burden you with meetings, but it's to stay. Remember that behavioral covenant, the idea that we're open to evaluation and review, and so that we're not going to just send you loose out there and hope for the best, but we want to keep in touch with you and make sure that you're getting what you need and that you're comfortable providing the kind of care that you're providing. Also, we looked into the question of insurance that came up last week, and the church is not able to cover anybody. And so our insurance carrier tells us that it is best if you have a personal auto policy that has certain coverages that are on this sheet. And if increasing your coverage to that level is a financial hardship to you, let me know and we'll find a way to address that. What I found is it may only increase your premium by $30 every 6 months or something like that. It's really not a lot, but we can help you even with that, because we don't want that to stand in the way of you giving somebody a ride to the hospital or something like that. So, and also it's always good to have if you own a home, you have a homeowner's policy, there's often some of that coverage sort of follows you around. Some people have umbrella coverage, which is a great idea, so talk to your insurance agent. I'm going to follow good boundaries and refer to an expert. Talk to your insurance agent. Say, I might be driving somebody to and from a hospital. What do you think? Tell me what. But this is what our church insurance agent recommends, this kind of coverage for volunteer drivers. So, I'm delighted that we've had this time together, and I appreciate all of you for coming out these 2 Wednesday nights. I hope you'll pray about
what's on these sheets, and then you'll get them back to me, and we can start finding a way to get you connected with people in the congregation who need care. And so I want to thank you for your time, and if you're on the fence, I want to encourage you to go to God in prayer. And this may not be the right time for you to do something like this, but maybe it is. And so I hope you'll consider that. Are there any last questions before we adjourn? And if I don't hear from you in the next 2 weeks, you'll hear from me. I know who's here. And I'll follow up on these sheets. So, any last questions before we adjourn? Let's say a prayer real quick. Dear Lord, thank you for this group. Thank you for the honor, the humility that we could have to enter into somebody else's life in a situation of care like this. What a privilege that is. And I pray that those who have been here at these training sessions will embrace that. And we thank you for this night, and ask that you give us a safe journey home and a good night's rest. In Jesus' name, amen. Thank you, everyone. And thanks to our
I need to get the tape.
There you go.
Okay, good. I'm going to be able to say that I went to both.